Okay, hello everyone. Welcome to Oxygen Therapy and Critical Care, the case-based series. Today we are on the final session of the series, and our topic is final frequently asked questions and resources for oxygen and critical care. As usual, we are happy to have Dr. Rachael Kimani Njeri from Embagathi County Hospital, as well as Dr. Eunice Ngatia Buluma from Tigoni Hospital, both in Kenya. So before we begin, just a couple of reminders. We will be using the chat function for question and answer today. To access this, the button is at the bottom of your screen. So please send all questions, comments, answers, feedback through the chat box, and feel free to introduce yourself. If you have any tech issues, please send us a message through the chat. And today's session is being recorded, and your attendance is consent to being recorded. So thank you. And so with that, I will pass it on to Dr. Eunice to get us started.
Okay. Hi, everybody. Welcome to our final session. I hope you've been following the series. So today is more or less like a wrap up of the whole series and to see are there gaps that are just maybe so we'll go actually most of the topics that we've gone through, and then maybe just pick up a few we may be the things that we need to emphasize.
Dr. Eunice, you're breaking up a little bit. We can't quite hear what you're saying.
Oh, sorry. And now, is that okay?
Yes, now it's clear.
Okay. So we'll start with the our main topic. So we're going to go through 4 main topics that we have already gone through before. So the oxygen therapy, we'll go through some pointers in critical care, an overview of COVID-19, and then the obstetrics and the pediatric session. So as I mentioned, it's just a wrap up of what we have been doing before. So in oxygen therapy, as we go through the oxygen therapy, we want to find out what are the indications for oxygen therapy and what is the purpose of oxygen therapy. Maybe I can see we have we have like 12 participants. Maybe you can just write something small. What do you think? Why do we give oxygen? And what are some of the indications? Just write something small. Maybe let me give it a minute, and then we'll be able to discuss this. Yes, I can see most people have written hypoxemia, which is true. So actually the main, yes, hypoxemia oxygen will be administered to try and prevent the cells from going into anaerobic respiration. Okay, so to improve tissue perfusion in case of sicklers, thank you. I can see someone has written supplemental. So all your answers are correct. So our main indication for oxygen therapy for with hypoxemia. So your main increase the oxygen in the this hypoxemic
Hi,
patients.
Dr.
So why do we need oxygen?
It's breaking up again. I don't know if you're able to put your mic closer or sit closer to your computer, perhaps.
Okay, maybe let me change my settings to use my data instead of internet. Just give me a minute. I'm hoping, is it much better?
You're coming through very clearly.
You can't hear me? Oh, my.
Yes, yep, I can hear you.
Yes, you can hear me now?
Yes, thank you.
Okay. So as I was saying, the main indication for oxygen therapy is hypoxemia, and mainly for cellular respiration, and we need it for cellular respiration, and we're able to do most things in the body because of the oxygen. The oxygen is used and it helps in the, like as you can see in the mitochondria, we need the oxygen for aerobic respiration. And when oxygen is devoid or it is in low supply, we tend to go to anaerobic respiration and we accumulate lactate. That way, we don't even break down the components like the glucose to optimum ATP, which is used into giving the body energy. So without oxygen, you actually accumulate lactate as opposed to breaking down the components into the full aspect in which you would want to use it, like the ATP, into the ATP. So that is the main thing, and that's the main purpose of oxygen therapy. And when you look at it, it's from a cellular level. So if the cells they're oxygenated, many cells come together and they form tissues. So it means you're going to have well-perfused tissues, which when tissues are combined, they form organs, and your organs are able to function optimally, which in essence, when all organs come together, they form the organ system. So you need the oxygen so that you can be able to work well all the way from the cellular level and all the way to the systemic level. So that is the main reason why we give the oxygen therapy. Maybe you can scroll down. Yes, I've already touched on that. So the key point is oxygen is treatment for hypoxia, not breathlessness. Oxygen has not been proven to have any consistent effect on the sensation of breathlessness in hypoxemic patients. So the main thing is, as much as the patient is breathless, the main thing is you're trying to increase the oxygen so that the patient can have, instead of having the 21% that we breathe, So the patient is having more oxygen as they are breathing in, so that way it will help improve their oxygenation status, not necessarily to decrease the breathlessness. Your main aim is to give oxygen and to increase the oxygen level in the tissues. Maybe go down. So what are the optimal targets of oxygen therapy, and when should oxygen therapy be titrated upwards? I think we've gone through this very clearly when we were doing the series, and maybe even before we are seeing the algorithm there, but it will be nice to see, like, what is the lowest? How do we titrate when you find a patient? How do you decide, okay, I need to put this patient on oxygen therapy, and how do I determine what to give at any particular time? I wish there was someone who could be able to unmute and tell us something. Just take us through maybe something. Maybe one volunteer. Just tell us, maybe typically when you meet a patient, how do you decide? Do you give them oxygen, and how do you decide what to give? May we have one volunteer? Just 30 seconds. Tell us something.
Hi, good morning.
Yeah, thank you, Lillian.
All right, so what we do is we check the oxygen saturation, and sometimes too, depending on what you want to achieve. For example, in neonates, I know if they are premature, there are certain levels that you want to achieve. You don't want to go above certain levels. So based on that, sometimes we decide if we're going to be going to a the liters, how many liters of oxygen you're gonna actually start them on. And then for adults, I think we would normally go into a rebreather if we realize that the sats are in the 80s and the person is tachypnic. We'd normally give them like about the 15 liters of oxygen through the rebreather, and then you are reassessing, and depending on how they respond, the saturations are coming up, the respirations are trending down, then we would start to incrementally reduce the liters until they are more comfortable to even go to nasal cannula at less liters of oxygen, if that's what you're asking.
Yes, that's what I'm asking. At least now I wanted to hear from your side how we do things, which is true. So the first thing is, when you get a patient, you have to do a thorough assessment of the patient. See how the patient is breathing. Is the patient having is the patient having tachypnea? Is the patient in obvious respiratory distress? You can see the nasal, what the parameters we talked about respiratory distress, the nasal flaring, the indrawing of the chest. Yeah. Then you do your SpO2. You put your SpO2, as Lilian has correctly said. Then from that, you also check parameters like cyanosis, and even the general being, how is the patient, the consciousness, is the patient drowsy, such things. So once you get to assess what's the SpO2, is there things like cyanosis? So that determines what you're going to do next. Yeah. So we have different levels of what we can give. As we had said, the lowest level, you can start with simple nasal cannulas. Nasal cannulas, you can give from 1 to, you can push it to 5 liters per minute. And then if the nasal cannula, if you do not improve, yeah, and the patient's oxygen saturation does not improve beyond 90, you should escalate to a simple face mask, which is between 5 to 10 liters per minute. And if the patient does not improve, you give this an assessment of around maybe 30 minutes. If the patient does not improve, you escalate again to a non-rebreather mask with a reservoir. For this ones, you do 10 to 15 liters per minute. And yes, if the patient does not improve, you can continue escalating to high flow nasal cannula. You can escalate now even to NIV, CPAP, or you can even intubate the patient. So depending on how your patient is responding, that is how you're going to escalate the management of this patient. So I think maybe we have answered the question about titrating up. And still when we are there, I think maybe we can also talk about titrating downwards. Something of note is, in the same way, if you want to titrate downwards, maybe the patient is on a non-rebreather and you're doing your 10 to 15, maybe you go to the lowest, which is 10, and you find the patient is achieving adequate saturations of above 92%, and the patient is not dyspneic. So you can decide to titrate downwards. Titrating downwards means you go to the next best thing, which is the face mask, not decrease the oxygen in a non-rebreather below 10 liters per minute. So you need to go to the next step, which is a face mask. Because at times, even in the wards, you'll find people are trying to wean off, but they're weaning off on a non-rebreather, and then they put oxygen at like 6. So which is more of a disservice to the patient, because now the patient starts to rebreathe the carbon dioxide. So make sure you're always at the levels at which they're prescribed for anything. After the face mask, if the patient improves, you can step down to below 5 liters. Now you go to nasal prongs. So the same way we are escalating with the maximum margins is the same way we will de-escalate the care of the patient in oxygen therapy. So the key point here is oxygen is an essential part of a complete healthcare system and is a required treatment for a range of conditions across disciplines and age groups. Oxygen saturations measured by pulse oximeter should be considered as a vital sign, and it should be documented with other vital signs in patient assessment and management. And oxygen prescription should be documented in the patient records and drug charts. So yes, that's good. So what's the oxygen therapy in limited resources? COVID-19 and pneumonia. So key points is practical oxygen therapy, prevention infection in hospital staff. So when you suspect and confirm diagnosis of a COVID-19 patient, so you need to meet the case definition. Is it the case definition? Is it clinical? And are there any laboratory tests, like the immediate, like when we do the PCR, or right now we do the rapid antigen to confirm your diagnosis? And once you're able to suspect and identify a patient, what are you supposed to do next when you come into contact with a patient? So the first thing is you're supposed to start infection prevention, which means putting on a mask. This is one of the simplest things you can do. It can help reduce the spread of. So putting a mask on, and also as the healthcare provider, don't forget that you come first also. You need to protect yourself so that you can be able to serve as many patients as possible. So when you have a suspected severe pneumonia and confirm the need for oxygen, so adults or adolescents with fever or suspected respiratory infections +1, respiratory rate of greater than 22 breaths per minute, or altered mental status, or saturations of less than 90 on room air. And with a child, this is, now we are doing the definition of severe pneumonia or confirmed case of COVID. So like in a child, what are the signs we're looking for? The child will be coughing, difficulty in breathing, and at least one of the following. And remember when you did the PID series, some of these things were the danger signs that you need to watch out for. If you see cyanosis, if you see saturations that are less than 90, there is distress like grunting, severe chest indrawing, signs of pneumonia, inability to breastfeed. So you look out for these signs. So these signs are the ones that will guide you to know when to start your oxygen therapy and how to start it. So you're supposed to start oxygen therapy for all patients when the saturation is less than 90 on room air. So as we had said, you can start with the nasal cannulas or the nasal prongs, even in children, and then you can continue escalating. So, and even as you put the nasal cannulas, you should not forget to the patient should retain their surgical mask. So this way you prevent the aerosols from aerosolizing the air and spreading, if it is COVID-19, to other patients or to other healthcare workers. Of note is like the nasal prongs do not have a high rate of the aerosols, but the higher the oxygen therapy you institute, the more the aerosols will be generated. So you have to keep that in mind. So for most patients, we want the target to be around above 92 to 96 or 95% saturations. But don't forget, we say pregnant women, we aim for higher saturations. For them, we want their saturations to be around 95%, because for obvious reasons, a pregnant woman has a higher requirement due to their fetus. So those are some of the things you need to keep in mind as you either decide to escalate giving your oxygen therapy. And as we have said, if the oxygen, whatever you're giving, does not improve, do not waste time. Like 30 minutes, if the patient is not improving, escalate to the next level. If you need to do mechanical ventilation, you have to intervene early. Intervene if you do not have the facility, refer the patient early. So maybe you can scroll down. What are the preferred devices in administering oxygen? And what determines the duration of time oxygen therapy is needed? And how is, so I think I have actually talked about all this when I was talking, even what are the different methods of oxygen therapy. So I think we have already discussed what are the preferred devices, we've already talked about them, and even weaning. As I was talking about the escalation, I also talked about the weaning. So we're going to go to key points. Oxygen therapy treats hypoxemia. It does not assist with ventilation or work of breathing. Methods of oxygen therapy can be considered in several ways. So you need to consider what is your source of oxygen. Is it a cylinder? Is it a concentrator? Is it a plant or a liquid tank? So all these things are available. Maybe different facilities have different sources of oxygen. So delivery of oxygen can either be invasive or non-invasive. I think we can remember how we classified them. Most of them are non-invasive. The nasal prongs, the face masks, even including the NIV. But when you intubate or you end up using a laryngeal mask, that is an invasive form of ventilation. So the flow of oxygen, it can either be low flow, like the nasal cannula, or high flow when we go to the the nasal prongs are low flow, but the nasal cannulas are high flow oxygen therapy. Patients must be monitored continuously to determine their need for oxygen and their need for support of breathing. Pulse oximeter must be available and used to assess patients receiving oxygen therapy, and the best oxygen source and delivery device is the one that is available at that particular time. Okay. So maybe another one thing that we need to also go through, as we are talking about, we're wondering, why do we need to wean down the oxygen? And why do we need to use the appropriate level of oxygen at any given time? So oxygen is a drug, and every drug may have its own side effects. So this is one of the things. When you have too much oxygen, you can form oxygen radicals, which can damage your vessels. In neonates, one of the things that has been seen is actually they get retinopathy that is induced by hyperoxia. So you can also induce hypercapnia. And then you can also have direct pulmonary toxicity, which can lead to atelectasis. And then also you can also damage the coronary arteries with the oxygen radicals, and you end up causing vasoconstriction. And also due to those radicals, you can cause some cellular injuries and cause some sort of systemic inflammation. Maybe you can go down, Sarah. Yes, so that is a summary of what the complications of administering excess oxygen to the patient. I think you'll have access to these notes also towards the end. So the key points to carry home is oxygen therapy can lead to retinopathy of prematurity in neonates. Hyperoxia can lead to oxidative stress throughout the body. So monitor SpO2 frequently to adjust the flow of oxygen, and do not target to have 100% saturation. That does not serve the purpose. We've said our target, if you can have patients saturating between 92 and 94%, that is adequate. So use that as a guide to keep titrating the oxygen downwards. So wean oxygen as soon as possible and aim to decrease the FiO2 to less than 0.6. So there's a question there, which you will answer in the chat box. Is it true or false? Oxygen delivery by a non-rebreather mask with reservoir bag at 15 liters per minute is considered high flow oxygen therapy. So is a non-rebreather at 15 liters per minute considered a high flow oxygen therapy? They can give like a minute. Are there any more people who want to participate? I can see 8 out of 7. You can use the poll in a few seconds. They can watch our video and then we can answer this question confidently. Maybe you can close the poll. Okay.
So what is high flow therapy? High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets or exceeds their inspiratory flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words, if someone was standing next to you right now with a radar gun pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow, or even exceeding it. If an oxygen device delivers less than the patient's inspiratory flow, then the delivery is called low flow. So, because the average adult who is at rest inhales at a speed or flow of 20 to 30 liters per minute, a high flow device should be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to maximize patient tolerance and comfort. And sometimes you'll see high flow therapy described as heated and humidified high flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC or even HFOT or HFT or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high-flow humidified oxygen delivery device. Now, like other high-flow devices, they deliver a high flow of oxygen and it is heated and humidified to help meet patient comfort and tolerance. And some devices, like Vapotherm's Precision Flow, go up to 40 liters per minute. Others, like the F&P Airvo 2, go up to 60 liters of flow, while still others can go even higher. Because at the end of the day, we're just trying to meet the inspiratory flow of a patient. And when that patient is in respiratory distress, that inspiratory demand can be as high as 100 liters per minute. Yikes. So, should high flow therapy be a replacement to other forms of therapy like non invasive ventilation? The answer? Absolutely not. High flow oxygen delivers just that, a high flow of oxygen. But sometimes patients have issues with CO2 or ventilation, and not just issues with O2 or oxygenation. NIV is effective for both oxygenation and ventilation. This is why HFT and NIV are often used together on some patients in a complementary fashion. For example, some patients may be on high flow therapy but require more support. Clinicians sometimes escalate to NIV to prevent, if possible, intubation and invasive mechanical ventilation. And if a patient is on NIV and can tolerate short breaks, clinicians sometimes switch to high flow therapy to allow the patient to have that temporary break from NIV where they can eat, talk with their relatives, take an oral medication. You get the idea. In fact, in a Vapotherm sponsored study, there were 104 patients who presented to the ER in respiratory distress, and they were initially placed on high flow oxygen. Of those 104 patients, unfortunately, 27 of them failed. And of the 27, 4 were immediately intubated. But the other 23 patients were switched from the high flow oxygen to NIV. And of the 23 patients who failed with high flow oxygen and were switched to NIV, 20 of them improved and did not need further escalation to intubation. In fact, in another study, patients at high risk of post-extubation failure were placed in one of two categories. The first category was high flow therapy only, and the other group allowed for both NIV and high flow therapy. Now, the patients that went on both NIV and HFT had a significantly lower rate of reintubation versus the group that went on HFT only. So don't get confused. HFT is definitely not mask-free NIV, but it is a great tool to treat patients with oxygenation issues who are in respiratory distress. So, just a quick final summary on high flow therapy. High flow oxygen therapy usually delivers oxygen at a flow rate equal to or higher than the patient's actual inspiratory flow rate. It should be heated and humidified for patient tolerance, and depending on the flow rate and the seal around the nose and mouth, high flow oxygen may create a CPAP effect, although we don't know exactly how much. It also may wash out some CO2 that is in the upper airway, which is often referred to as CO2 dead space washout, but again, we don't know exactly how much. So that's your quick introduction to high flow therapy.
Okay. So, did that play both videos? Yeah, okay.
Would you like to play the second video as well?
Yeah, I think mainly I think it's already been summarized. So there's no need. So to answer our question, is a non-rebreather high flow or low flow? So from that video, we have seen it is a low flow device. So anything that will give you above 30 liters per minute is what we'll call high flow oxygen therapy, like the nasal cannula. And we have seen the nasal cannulas we've said you need to humidify for patient comfort, to set the FiO2, and you have to also set the temperature setting. So what are the key points? Normal adults from the flow rate of 20 to 30 liters per minute of oxygen. Patients in respiratory distress breathe at higher flows. High flow oxygen therapy requires a special machine to generate flows that are greater than the flows generated naturally by the patient. High flow oxygen therapy requires a specialized nasal cannula or prongs devices. High flow oxygen therapy requires humidification, heat and humidification. And high flow oxygen therapy does not assist with ventilation. That is clearance of the CO2. So that is what you need to keep in mind. And we have said it's not a replacement. So most of the time you'll notice that we used these devices a lot during COVID, as at times as you're waiting for maybe the vent to be available, but they are maybe most of the time an intermediary as you're waiting for intubation or you're waiting to put the patient in an non-invasive ventilation. Then another topic that we already went through, how is oxygen therapy provided when a patient is in prone position? So we went through this topic and we saw how prone position is beneficial to patients, and you can actually, any therapy, any oxygen therapy can actually be given when a patient is in prone position, including even an intubated patient. But the main thing is you have to remember is that you have to secure the airway, especially if the patient is unconscious, and you have to have someone on standby to be able to, in case the airway dislodges or the patient starts to be apneic or the cardiovascular, maybe they collapse. So you need to always watch the patient. So for patients who are alert and are able to prone, you should be able to give them instructions, help them to know how to prone. But in general, all oxygen therapy methods can be used in prone positions. So the other question is, overview, how is ARDS managed and what ventilator modes are used for ARDS? So when we went through ARDS, there are some things that we discussed about ARDS. The main thing was it is an acute illness that occurs in less than 7 days. The patient will have difficulty in oxygenation. So for these patients, you want to have, we call them protective measures for these patients. So so when you set your vent, what are you going to look out for? So we had the main things that you needed to put a PEEP because the lungs of these patients were very stiff. So now you need to have a high PEEP in these patients. You need to set lower tidal volumes, but a high PEEP. And then the respirate will be a bit higher for this patient. And then the oxygen FiO2 will be relatively high. And then you can wean off as the patient improves. And one of the things that also helps in these patients also was proning. We had the option of once you intubate the patient is comfortable, you should also initiate the proning in this patient. So most of all these things that we talked about are in the resources that have been listed down there. Maybe you can scroll up, they can see the resources, and then maybe for more information, if you have a question, maybe a burning question, you can put it in the chat box, then we can address it. But right now we are doing more of an overview of the whole series. So we can continue. I don't know if Dr. Rachael is available. She's on.
Yeah, good evening. Thank you, Eunice, for that input. It was very informative, and at least it's a refresher from what we've been discussing. So I want to take up from here, and we're going to discuss just briefly on the critical care aspect. We all know that during the COVID pandemic, there was a lot of need in the critical care. So it's good to at least get to understand or rather have a refresher on the critical care. So the first thing is, how is critical care provided outside the ICU? Critical care can be provided outside the ICU. It doesn't necessarily need to be in an ICU. As long as you have the monitors, you have the expertise, that is the staffing, the doctors, the nurses, and you have people who understand how to manage the critical care patient and even the telltale signs to look out in managing a critical care patient, then you're able to manage a critically ill patient in an ICU, outside the ICU, especially in situations whereby your ICUs are full. So what will happen in a critical care unit is, the one outside the ICU is, you're going to ensure that you have everything. And then should you have a long stay patient who is also critically ill, if you're taken to a home facility, the patient needs to also have the monitors and the staffing that will understand what a critical care facility looks like. So the resources on this is available. And that's just the brief on the critical care facility. So the next thing is how are airways managed in critically ill patients. Just the same way you're going to manage the airways in a normal patient who requires oxygenation and all, whereby you have to make sure that the airway is patent, is the same way that the same notion that you have when you want to manage a critically ill patient. So if the patient is hypoxemic, you want to understand whether you need to intubate the patient depending on the levels of oxygen and what are the requirements that the patient have, or are their SpO2s extremely low, or are they just marginally low? Are they in the 80s to 85, where you now decide to have oxygen devices supplementing for oxygen. So ensuring that the airways are patent is important. So you'll also check whether there are secretions or whether there are obstructions that are causing the patient to not be able to have adequate oxygenation. Sorry, it's my daughter. Just 1 minute. The other thing is, how do you manage multiple emergencies in a critical facility? So you try, in most hospitals, what you want to do is try and identify the most severe patients when you're having multiple emergencies, the patients that need immediate attention, the patient that's urgent, and then there's the immediate. So you want to identify which patients are the most urgent at that point. And then based on that, you're able to understand on how to manage the multiple emergencies. How do you monitor quality of critical care? What are the best indicators for variable resource settings? I'd like to hear from a few, like the ones who have ICU facilities in their hospital. How do you monitor your quality of care of the critical care? I can give a minute to this. You can write it on the chat box.
While everyone is answering, I think there's a question for Dr. Eunice in the chat. Jonah asked, in the absence of SpO2, how do you manage oxygen administration?
That's a good question. When you do not have SpO2 in the patient, the main thing is you need to check how is the patient doing. And from what we said last time, if you have a patient, especially an adult, has above 22 breaths per minute, and the patient is in obvious respiratory distress, even without your SpO2, you need to assume that this patient is not saturating well. So you initiate your oxygen therapy. So those are some of the things you need to take into account, mainly the clinical picture of the patient. Then that can guide you. You start your oxygen therapy as you look for your SpO2.
Yes. Thank you. I think she's clarified that. John, I hope that's adequate. So back to the question is, how do you monitor the quality of care? There's Karanja, Lillian, who's talked about having specific indices. So you check on accidental intubation. What are the rates of accidental intubations? What are the rates of having VAP, ventilator-associated pneumonia in the facility? And what is the rate of readmissions within a period you can set between 48 to 72 hours back into the ICU? So this tells you this gives an indication on what kind of care is being offered. Is the care adequate, and is it optimum? So every facility can have different indicators depending on what kind of patients they have and what kind of diseases they're managing. And then from there, you're able to assess, are the patients improving or not, or is the facility doing worse? Are we having more mortalities from the ICU? And if they're having more mortalities, are they mortalities that you would have avoided? Yeah, that's all I can say about now the quality of care. So there's something called essential emergency and critical care. So it's now analyzing, there's the reality and there's the best practice. So you want to identify what are the gaps. And then once you identify those gaps, maybe your gaps could be staffing. You're not adequately staffed, whereby it's ideally supposed to be 1:1. Your gaps could be issues with the lab. If you do not have an adequate lab that's offering your results within an instant period of time. So you identify those gaps, and then once you see those gaps are causing are affecting the quality of care that you're offering, then now you have goals. You set up goals that are now going to help you manage, going to help you run your facility adequately so that you have the best practice. It's always good to reassess, maybe after every 2 or 3 months in a facility, so that you're able to follow up accordingly. The other question is, how do you manage sedation and choose medications for patients who require prolonged sedation for more than 7 days? I can request somebody to at least state something on the chat box concerning this on sedation in the ICU. Can give a minute to that. Anybody who can, you can unmute yourself and say something. Okay, in view of time, I can just go ahead ahead with it. So when it comes to sedation in the ICU, you need to first identify where are you sedating the patient. Is it a patient with hypoxic brain injury? Oh, sorry, I'm seeing someone has posted. Lilian says, where indicated it's best to use awake sedation. It's best linked to decrease episodes of ICU delirium. Yes. So you need to identify what is the reason or have a reason behind why you need to sedate the patient. So are you having a patient with traumatic brain injury? Or are you having a patient who has ARDS and has ventilator asynchrony? Or are you having a patient, was it post-surgical? Maybe they had prolonged surgery, craniotomy, and you require you want to keep the brain rested for maybe about 48 to 72 hours. So once you identify the root cause of why you want to have the patient sedated, is then now when you decide what drugs to use. More often than not, we have the midazolams and you have the opioids that we use to sedate the patient. But you also have to be keen when you're sedating based on, you have to check on their vitals, especially their blood pressures. Midazolam is known to reduce the blood pressures in patients, especially in the ICU, when you have it offered as a sedative agent. So having a patient who you've understood what is the cause of the sedation, you then now decide what agent to use. Can I go back? So here are some of the resources that can direct you towards information on the critical care that I think you can go through it in your free time. In case you have any question, you can write it on the chat box as we go ahead. Welcome, Eunice. Eunice, are you there? All right, go. I can go ahead. Okay, I'll just go ahead. So now it's a reminder on COVID-19. So how are severely hypoxic COVID-19 patients treated? Okay, at this point in time, we're not dealing with much of COVID-19, especially in our facilities. I think most of the people now are either symptomatic. So most of the ICU facilities do not have any patients admitted with COVID-19. So, but at least it's good to understand because COVID-19 now brought the issue of ARDS and patients who are really severely sick and had ARDS. So understanding it at least gives us an indication of how to manage it should it come back, hoping that it doesn't. So what was happening is most of the patients were symptomatic and they had mild and moderate and severe critical illness. And treatment was based, oxygen therapy was based on the severity of the disease. So depending on how severe the patient was is when you'd be able to decide when to supplement oxygen and how to supplement it and at how many liters to supplement the oxygen for each patient. So in the ones who are not too severely sick, you'd start with nasal prongs or oxygen mask, and you'd give at different rates and then wait and see how the response would be. But with most patients, they ended up having, you'd have to have your high nasal flow cannulas that will give a high flow of oxygen, or at the end, or even some would have non-invasive ventilation, and you'd be forced to use either BiPAP or CPAP, to at least be able to open up the lungs and put a high PEEP to at least recruit more alveoli that had already collapsed. So it all depends on the severity of the, or how severe the lung has been affected. And so that now you can be able to decide on what regimen to give. Can go down. So this is a Venturi mask. We all know it. It's also known to give high flow oxygen. So it's important so that at least you get higher liters per minute, depending on the severity of the patient. So this is just a reminder. Can we go down? This is what I've said. So you have different devices giving different amounts of oxygen. So you have the simple mask, which can give 7 to 10. You have your nasal cannula, which you can give 2 to 4. And you have the reservoir mask, which gives 15 liters. I think this had been discussed earlier, so you can continue. So when it comes to the BiPAP and the CPAP, these are the non-invasive modes. So in the non-invasive modes, the patient needs to be spontaneously breathing and has to be cooperative. And the aim is to try and recruit more and more alveoli so that oxygenation is improved and push out the water out of the lung so that now at least oxygenation is able to happen. So in CPAP and BiPAP, you also set a PEEP, positive and expiratory pressure, so that now you have alveoli recruited and open at the end of expiration. So it was the best treatment for hypoxemia in the spontaneously breathing patients, and it was used during that COVID period for patients who are spontaneously breathing. Can we go down? I don't know how long. How long is the video?
This is a long video. It's about 11 minutes.
Yeah. You
I can share the link if that works.
Yeah, you can share the link.
Thank you for watching this important video.
You can expand this. Yeah, she'll share the link on the video, then you can have a look at it at your free time. So when in patients with in patients who are intubated or in patients who are in the ICU, if you have too much positive pressure, it has adverse effects as well. So most of the time you'll have atelectasis or atelectrauma, you'll have air leaks, barotrauma, and you'll have overdistended. The barotrauma causes overdistension of the alveoli. So once you have this, this causes now less oxygenation and can affect the lung and eventually can affect the patient. Just go down. Just go down. This is just explaining what I've said on atelectasis and the barotrauma. How does essential emergency and critical care relate to COVID-19 response? I mean, during the COVID-19 period, we had a lot of critically ill patients and most of the ICUs were full. So having to understand that an ICU critical care doesn't just happen in the ICU was important so that you can be able to set up centers or units outside the ICU that will still manage the critical care patients. So for what I've discussed, these are the links for what was discussed above. So you can also have that at your free time. I think, I don't know if Eunice is back. Let me just ask her to unmute. Eunice, are you there? Maybe she's having internet challenges. So this is now in obstetric patients. We also went through this. So how does the approach for oxygen and critical care differ from pregnant women? In pregnant women, the oxygen demands are more, and oxygen should be given to pregnant women with hypoxia of less than 85. We understand that a lot of those pregnant women during that the oxygen demands increase, and they're prone to getting hypoxemia when their lungs are compensated or decompensated. So supplementing oxygen in patients in pregnant women who have signs of hypoxemia is important. The benefit of this, of course, is that the maternal blood supplies the placenta and the fetus, and then at the end of it all, the exchange happens in the fetal placental transfer, and you have oxygen also getting into the baby, which is also essential for the development of the child. So ensuring that the mother does not get into severe stages of hypoxemia is important. So the recommended target of SpO2 for pregnant women is usually between 92 and 95%. So you might not get 100, especially when they're lying down because of the splinting of the diaphragm. But when you have anything between 92 and 95, that is acceptable. So were there any specific protocols? The protocols were just the same, just assessing the amount of the levels of SpO2 and deciding when to give ox supplementation. And the mode of treatment was basically the same. Can go down. So on that, this is also available. You can have a look at it. So we'll then finalize with the pediatric patients. How is oxygen therapy provided for infants and children? The same oxygen devices that you use or that are available are the same ones that you'd also use for infants and children. You have your nasal prongs, your masks, your mask with a bag. These are the same devices that you can use to give oxygen depending on the levels of oxygen in the patient. So just the same protocol, they're given at different liters per minute, is the same thing. Are there COVID-19 protocols for pediatric patients? Yes, there were. And they were not so different because at the end of the day, it was just the amount of SpO2. So it was the level of oxygen that was the issue. And also now you treat depending on with the rest of the regimens that were available that were available. So you give, but the most important thing was the oxygen levels. Can go down. So different units had, the WHO had its own protocol. There's also the protocol from WFSA, and there's also the guideline in PICU for limited resource settings. So all these departments, or should I say societies, came up with different protocols, but at the end of the day, they were all somehow similar. So we've come to an end to the session. Can go down, Alana. So we all know, as Nelson Mandela said, education is the most powerful weapon which you can use to change the world. So we hope that during these 12 sessions, at least we have grabbed something, and that will make, we'll have key points, and that we'll have changes to make in our various facilities to improve the care and to also better the quality of care that we offer. So I'll leave this in case there's anyone with a question. Is anyone with a question before I hand over to Alana? I hope everyone has been getting their certificates on email. ECHO has been sending them directly to our emails, but maybe if you've not received yours, you can contact me or contact Alana, then I could follow it up for you. So I want to take this opportunity to say thank you to Assist International and ECHO, and also Stanford Medicine, the Division of Global Anesthesia, for putting this together. Thank you for all the support. We don't take it for granted. And yeah, we look forward for more sessions in the future. Thank you. Alana, over to you.
Thank you, Dr. Rachael. Thank you, Dr. Eunice. Just to wrap up the program, we wanted to thank everyone for calling in and participating and answering questions. As always, you're welcome to add additional questions on the WhatsApp group after the class is finished. And we encourage you to continue doing so even now that we've finished our 12-part series. And again, thank you to Dr. Anna for creating the curriculum, and special thanks to Dr. Rachel and Dr. Eunice for being such wonderful educators for this course. I see there's a question from Jonah about getting sessions and recordings. All of the session material, all of the recordings, as well as additional resources are available on the Learning Resource Center. I shared a link to the Resource Center on the chat earlier. So we encourage you to sign up there. The link will take you, will ask you to register, but registration is free. So definitely encourage you to do that, and it will grant you access to a number of resources for this course, as well as many other courses that our team is working on. As of now, we do not have current plans for another ECHO telementoring program, but we are working on it. And so if you sign up for this course, you may hear from us in the next few months about potential opportunities to participate in other courses, other topics as well. If you have any particular topics of interest that you would like to see covered, you're also welcome to email or WhatsApp me. I'll share the link to that in the chat. And so that's it for me. And thank you again. And we hope to continue being in touch with all of you.
Thank you so much. Everyone have a lovely evening. Thank you.